Hi, it's Kristen here at UT Southwestern Medical Center today for our Facebook Live chat on sickle cell disease. We are happy to be here today with Dr. Alecia Nero. Dr. Nero, cares for patients with non-cancerous blood and bone marrow conditions and leads UT Southwestern's pioneering transition sickle cell program. She's also a translational science awarded funded scholar in our clinical science department. So before we get started with our chat, I want to thank both Children's Health as well as the Center for Cancer and Blood Disorders at Children. They were both strong proponents of this chat, so we appreciate that. And don't forget that as we move along through the chat, be sure to like and share the conversation, ask questions in the comments feed of the live stream, and we will take as many of them as we can get to. So again, we're going to get started now on sickle cell disease. Thank you for joining us, Dr. Nero.
Well, thanks for having me today.
You know, it's a new experience. So, I mean, with sickle cell, what are the most common misconceptions that are out there?
Actually, there's several. One of the big ones is that sickle cell is one thing instead of multiple disease types. So they're distinct types of disease.
Okay.
A lot of the other thing is that all patients with sickle cell are very, very sick and they can't work, can't go to school, lead normal lives, and that's not necessarily true. Some people may, but not all.
Okay.
There's a lot of confusion between sickle cell disease and sickle cell trait, which are very different entities.
Okay.
And one of the big ones that our patients tend to battle with is the stigma and that patients with sickle cell disease tend to be drug seeking or drug seeking more than the average population.
Okay. Okay, so you mentioned that there's a difference between sickle cell disease and sickle cell trait.
Yes.
Could you tell what is that?
So the trait is a carrier status where someone inherits a sickle hemoglobin and a normal hemoglobin.
Okay.
So they're carriers and most of the time do not know, not anemic, do not manifest clinical symptoms. There are a couple of rare things that people with traits should be knowledgeable about. However, full-blown disease, there are many types, and they have two abnormal hemoglobin, at least one of which is a sickle gene.
Okay.
And they then manifest the clinical complications of what we care for in our clinics.
Okay. So what are the various types of sickle cell disease? You mentioned that a minute ago that there's more than one.
Yes, there are a list of them. The most common in this country is SS.
Okay.
Secondary, then we have SC, we have sickle beta thalassemia, various types of that. Right. SE, and so they're a long list, but usually patients, hematologists will diagnose them and they should know their type, which is important for them to have that discussion with their provider. Okay.
All right, so we've got our first question from Christy. Christy says, hi, first of all. She says, which type of sickle cell is most life-threatening, and are all sickle cell diseases genetic?
Yes, so it is a genetically inherited disorder. People inherit this in a very predictable fashion from parents. They have it from the time they're born, and it's lifelong. As far as which is most life-threatening, that then becomes, it's a little bit of a tricky question because some people do well with different types. We tend to say patients with SS may have worse, but that is not particularly true. All our patients are at risk for serious life-threatening complications. And so it's really, hard to say that patients with other types can't be affected.
Okay, this is a good question, Christy. And related to that, I mean, can sickle cell lead to more serious health complications?
Yes, so because it's a blood disorder and blood goes to every organ, pretty much there's not an organ system that's spared for a sickle cell complication. Okay. And so that's why it's so important and why we get, we diagnose at birth so we can bring babies in so we can prevent and teach parents and families. Our adult patients, particularly as our patients age, we deal with organ damage. So we do a lot of kind of teaching and preventive so we don't go down those roads.
Okay, so we get another question in, and so you talked a little bit about this just now. He said, is it found at birth or can it develop later?
So it doesn't develop later. Some people can be diagnosed later, right?
So
it was there, they may have had a very mild form, and just wasn't picked up, or before the timing of newborn screening, because now all 50 U.S. states screen. However, if you were after that time, came from another country where they don't screen, or someone misunderstood the newborn screening, then we see rare cases where, but it was always there. It's not something you catch or develop later in life.
So it is. So at least here in the United States, it is part of the newborn screening program. That when a baby is born, they do this battery of tests.
Yes.
Okay. Well, then you mentioned, it's genetic. So does it come passed down from both parents or one or the other?
So we can't blame mom or dad. Some people try to blame their significant others. So each person is equally, involved. So basically, we inherit one hemoglobin from each parent. So if you happen to get abnormal ones from each parent, then that's how it's passed.
So what are some of the common symptoms that you see in practice, or that people might not know to come to a doctor about?
So I think the biggest thing that brings patients in, particularly our adult patients, is pain. So it's very common pain, but other symptoms can include stroke, severe lung complications, which we call acute chest syndrome, particularly in some of our younger patients, a lot of spleen issues. We do have adults who have spleen issues, so sometimes that's another misconception, that adult patients don't have spleen complications, and that's where your type matters. Eye disease, kidney disease, so like I say, every organ.
There's a range of things there.
Yes.
So related to this, and we talked about this earlier, but Anna had a good question. She says, are there various types of sickle cell disease? And I know you mentioned earlier that there are multiple types, and that it's important to get diagnosed or as early as possible?
Yes. And so it helps to stratify. There are certain things when we know your type, you may be a higher risk, even though all patients may be at risk for something. The risk in one group or one disease may be higher than in another. So that's why it's important to know your type.
All right, so we got some more questions coming in.
Sure.
So, we've got one, let's see, from Natasha. Natasha says, what are some of the best practices in managing the disease?
Wow, well, there are a lot. We do a lot of screening. We start early on with screening for the eyes so we can catch eye damage early. In our practice, we do screen for kidney disease early. Vaccination, so one of the biggest things that used to kill our patients, but because we do so well with infections now, infections. So fever is always an emergency in a sickle cell patient and need evaluation. Getting vaccinated to protect against infections are helpful for all the preventable things, because our patients are at higher risk for infections.
Gotcha. Yeah, that's a good question, Natasha. So I noticed that when we were doing the research for this, it seemed like the sickle cell patients are often hospitalized often. I mean, at least that's what we were able to tell. I mean, is that accurate? And when should somebody go to the hospital?
So, excellent question. And again, it varies. So as far as, it seems very frequent. We have pretty much, it's a smaller population of our total population that go to the hospital a lot. And then we have some patients that we rarely see in the hospital. They come to the clinics and they do relatively well and go on with their lives. But yes, there are some patients who come in quite a bit with pain. I think the best advice for patients and families is, if there is something that's just not right, not like the usual sickle cell stuff that you've been taught to manage at home, that you should come in for sure. Any signs of infection, come in. Pain that is not working with your pain meds at home and stays persistent. Any stroke symptoms, respiratory symptoms, those things need to be evaluated.
So things that are out of the ordinary or excessive
for that particular person, because we have some people who have a lot of pain most days and they don't have to come to the hospital. But if that changes, then they may need to.
All right, so we've got a question from Betty. So Betty says, after bone marrow transplant and no symptoms for more than 25 years, why would a patient suddenly start having symptoms again? He said the bone marrow transplant is supposed to be a cure.
Yes, it is supposed to be a cure. So that would be something I'd probably, recommend Betty follow up with her transplant team. A lot of times they do long-term follow-up and they can see how much donor versus, how much patient. I'm not sure where we started with Betty's age, but then other things happen that, that are non-sickle related that could be causing that. So to distinguish, is it related to sickle cell, or is it something else, arthritis, something different?
So Betty, it sounds like in this case, it'd be good to touch base with your transplant team.
Absolutely.
All right. Now, I know this chat is partly supported by Children's Health, and you're very involved, or you actually started the transition program from adult children to adult. And what does that look like? And that's a big step, just transitioning from pediatrics to adult care. So what are some tips to make that smooth? Because I know we do have some parents involved.
So the transition program that started, so we were, prior to me coming here, patients were being transitioned to adult care because we have an adult program, we have a pediatric program. And then I jumped in with med-peds, and we've kind of ramped up our adult team, and so we have pretty much a mirrored program, and we have systems and flows and pathways in place to get the children across. We start early on the side of pediatrics. We've developed a curriculum, so that's kind of a lot of stuff that I did with the pediatric team. And we all meet as a group. So transition, I guess the first point I have is transition is not just a pediatric responsibility. You got to have your adult champion to help navigate the system, which is the hardest part for our patients.
Right.
And then the communication flow between the teams, it helps.
Okay.
As much as we'd like to operationalize and have like systematic and practice, transition, it should really be catered to the patients and families. However, at Children's we have an age cutoff, so we start earlier if we know we need more time with that family to get them ready and get everything in place so they don't lose care, because they should never lose care.
So are there things that pediatric patients themselves, as they age, as they're getting closer to that transition period, that they can be doing to help?
Well, yes, in conjunction with the parents, what we need is our patients to be, the independence of the patient. So parents kind of pushing the children. So for instance, we set goals. You come to clinic this time, we introduced what our long-term goals are, all the way up to 18. So we may be having this discussion at 12 or 10 as what are we going to do for the next 8 years? And then we start breaking it into manageable bits. These patients have a lot going on when they turn 18, other than sickle cell. They go to school, work, other things. And so this is the hard part. So we want that part to be seamless. So a lot of the education, we try to have direct contact where the patients can answer the questions themselves. They understand their medical history, their medications, how to access care, how to get to doctor's appointments. And so we have all this stuff built into curriculum and folders for them.
Okay, that sounds like you help them along the path. So, Betty asked about, the bone marrow transplant. What other treatments are available for somebody that's been diagnosed with sickle cell disease?
So we still call bone marrow transplant, our only cure. We do have now gene therapy as an option. And so there are a couple of places across the country that are doing it. I believe the first child that had the gene therapy was in France and maintained a clinical remission from the sickle cell to date. At least the last paper was over 15 months long. So that was very encouraging, and so now there are trials within the U.S. that people can look into, because not everyone has a match or has difficulty with that. Other treatments, prior to this summer, hydroxyurea, which is an oral medication by mouth, is something that we use a lot to control, and it's almost like our standard of care for our patients with SS, again, knowing your type. And then this summer, there was another medication that was FDA approved for sickle cell, which mostly was approved based off of pain. Okay.
So related to that, are there any, pain is a big issue. Are there any things people can do at home to address the pain?
So I think one of the most important things are for our patients to first know, what is your trigger for pain? Some patients have pain outside of any kind of trigger, but a lot of our patients tend to know when the weather gets cold, when I'm dehydrated, those kinds of things, when I'm very stressed out.
So it causes all of us to have pain.
Everybody has pain when they're stressed. So if we can avoid the triggers, the best thing to do is avoid pain, then have to treat pain. And then, as far as managing the pain, most of our patients tend to have pain medication at home, and the parents have pain medication. But rest, hydration, some people, the warmth, so they use heating pads and warm packs and things like that. Some people, rubs help. But it varies from person to person.
So there are options that they could do, though.
There are things that people can do. Distraction is really good. So people, music, art, other kinds of therapy help with the pain.
So when it's pain, is it full body pain, or is it usually localized to a specific area?
All of the above.
All of the above.
So sometimes it can be localized pain. In some people, it's all over. Starts one place, goes to another place. And so we're kind of more talking about the acute pain episode. We do have some patients who have irreversible damage to joints, and that kind of just hurts chronically. And so that kind of doesn't go into kind of nagging, dull pain. So it just varies on what kind of pain, which is also important for our patients to separate their different pains, because it may not all be the same.
Okay. So we've got some more questions. So this one's from Tanya. She says, what makes your program different than other sickle cell programs in the DFW area?
So we're very unique in the fact that we have a mirrored program, so a pediatric and adult sickle cell dedicated program. So we have staff dedicated on both sides. We have APPs, we have a community health worker, we have dedicated nursing, social work, and all these people only do sickle cell. So that right there sets us very different from most centers that do not really cater to the sickle cell population.
It's good to know. All right, so let's see. This is something you wanted to talk about earlier. So we've got a question. This one came in. Are there any promising research and or trials on the horizon? I know this was something you wanted to address.
Well, they're depending on what we're talking about. I mean, there are different studies ongoing, including, like I said, the ones that are enrolling for gene therapy and all of that. It's really hard to say, you know, how soon these would be tangible. It's hard, you know, to say that, because a lot of these are early and need a lot more time to go. But I mean, people are out there trying to work and provide patients more options, because we're very limited in the options that we offer patients today.
Okay. So while we have a minute, I want to say thanks again to Children's Health and to the Center for Cancer and Blood Disorders. We are happy to have your support of this chat. We've got about 10 minutes left. We're almost done. So get those questions rolling in, and we'll take as many of them as we can. So the next question is from Natasha. And Natasha's wondering, she says, how do you go about creating a treatment plan when the patient has other health impairments?
I'm not sure, you know, what other type of health impairments, but I mean, really that's where you have to individualize a person. You know, sickle cell, like she mentioned, you know, our patients may have multiple things, so we commonly do that. We have patients with several other diseases other than their sickle cell. It helps if you can work, if they have other specialists. So someone who can coordinate among providers. Our patients tend to see us a lot, so we take a lot of ownership, and sickle cell can affect other things. So our patients with diabetes, or heart failure, we have those types of things that we, you know, work with the other specialists in co-managing.
Gotcha. So in that case, do you all usually take the lead, or do you keep just collaborating?
A lot of times it depends on the issue and which one is worse. So, you know, some of our patients have bad lung disease, pulmonary hypertension, and that's the biggest thing. And their sickle cell is causing very little damage. We're managing the sickle cell the best we can, but they're seeing the pulmonologist and those specialists. Sometimes the sickle cell is the worst, and it's affecting everything else that can be done. Someone's lupus or whatever else, and so therefore it's, you know, it just varies on what's going on with that individual, but it has to be very individualized for the patient.
So related to that, now I think this is going to be a very similar answer, but how long does an average crisis last for somebody? Is that a couple hours, a couple days?
Again, so this is, you know, one of the things that are heavily debated, because sometimes people refer to pain and everything as crisis. So, you know, but crisis is something that comes on, has a finite period of time, and gets better. And our patients may go from a pain state, increased pain state, back to their usual pain state. So that can be hard and tricky for people to understand. You know, if you ask most adult providers, they might say for hospitalization, maybe 4, you know, to 5 days. I've had patients who it's only in the order of hours, So it can vary person to person. And I think the other thing is, you know, some of our patients have pain, we actually discharge them in pain. But where it's manageable, that they can take care of themselves at home and they don't necessarily need to be in a hospital setting.
So is there a specific definition for this is what a crisis looks like? Or is it, again, up to each individual patient?
So a lot of times, you know, we're taking the patient information. So it's kind of a partnership with doctor and patient. We are basically taking what they're telling us and their daily reports of the pain and how it's acting in their body, and also trying to rule out some other things, because sometimes something can happen acutely. A bone infarct might, you know, happen
cause something.
And so basically the definition of that is very fluid and it can vary some. So I don't want to lock in that it's an exact something, because some patients, and we have seen some patients who have been longer than what we would expect.
Right.
And so those are more rare, but it does happen.
Okay. So let's see, we've got some more coming in. We are doing great.
Fantastic.
We've got one from Janice. She says, sickle cell affects the blood, so how often is blood used in the treatment of an individual with sickle cell disease?
Often.
Often,
yeah. So basically, for our very serious life-threatening events, we use blood to minimize. So we give our patients unsickled red blood cells to treat the disease. The patient comes in with stroke. We often do things what we call a blood exchange. So where we can do a simple transfusion where we just put in an IV and give you blood, or we can put in lines and remove the sickle blood and put all unsickled blood, because we want to quickly drop the amount of sickle hemoglobin in the body.
Gotcha. So you just replace the transfusion.
Yes.
That's fascinating.
Yes.
So
one of our biggest treatments. So sorry if I left that out. Thanks.
No, so that's the red cell exchange.
Well,
or is that something different?
No. Well, that's what we just talked about. Yes.
Okay. Just wanted to make sure we're clarifying. So we have one other question here. Let's see. Can a person with sickle cell trait experience pain similar to those with the disease?
So we have seen in extreme circumstances and with patients with sickle cell trait undergoing like this massive body sickling event.
Okay.
And so I think a lot of this information first started coming out from the U.S. military and massive, pain events. We've seen spleen events in patients with sickle cell traits going to high altitude.
Oh.
So when you shift someone, so for most day-to-day living, we're not seeing that in, for a sickle cell trait, but you can push them to a state in an extreme circumstance that's not in usual day-to-day living and see some rare sickle complications.
Okay, that makes sense. Well, let's see what else we got. All right, so we talked about that. I'm just going through all of our questions. Thank you for all the wonderful questions that are coming in. They look really good. So again, let's see. Somebody was asking if you could explain again a little bit about the red cell exchange. What happens there? Is it purely a transfusion?
Yes, so it's all red blood cells. So like I said, the one way we can give blood is what we call a simple transfusion, where we put in an IV and we order so many units, a unit of blood, and run it straight, and that's all there is to it. Okay. We can also calculate how much blood we need to give to drop the sickle hemoglobin low, in which case a lot of times here at our center we do it by machine, but you can also, there's a manual way to do it where you take off the sickle blood and give unsickled blood, and that's where you're exchanging the patient.
So we're going to go back to the pediatric part for a second. If you're a parent and you have a child that has been diagnosed with sickle cell disease, are there a certain number of times they should be going to the physician, or is there a certain frequency that they should be checking in?
Yes. So early on, we bring the patients and family in more frequently, and then we then see what kind of clinical complications within the first 4 to 6 months, and some of our patients who keep their fetal hemoglobin a little bit longer. They may be a little older before they actually start manifesting with any symptoms. And again, it depends on the type as well. So again, earlier on, we're bringing our patients, even when they look healthy and well, and then when there are any episodes.
So we've got another one from Janice. She says, are there differences in how sickle cell affects men and women?
So very good question. I think some of the stuff that we see, so we have, for instance, with women, there's, I don't know if I should use the word a lot, but we have several patients who describe increased pain episodes surrounding their menses, either when they're ovulating or having, their periods and things like that. For the most part, men and women are at risk for, similar complications.
Right. So it may just be a little bit more pronounced at certain times for women. Is that what we're saying?
Well, it can be. So we've seen it with, menstrual, so that's been documented. And particularly in women around childbearing, we can have increased complications and things like that.
Interesting. Very good question. So I think we got time for maybe 2 more questions. The first one is, can you talk about sickle trait and sports?
Oh, that was a highly debated one. So once the NCAA started putting the recommendation to sign a waiver or get tested. So I think it's important for everybody to know their trait status. So that's very essential as well. As far as sports, we encourage that in a lot of our patients like sports and do sports that they can tolerate. So we encourage sports even in our patients with disease based off of what they can do clinically.
Okay.
So in people with trait, it shouldn't be an issue. I think what the issue was, and when the media really got a hold of it, was there were some sudden deaths. Again, we talked about the military being the one.
Right.
In situations that probably were avoidable if hydration was appropriate, rest periods were appropriate.
Okay.
So once you push the human body beyond where it should go, sometimes you see things happening.
Yeah.
And so I think most hematologists and people who do sickle cell feel that we don't want to stigmatize people with trait.
Okay.
They should be, able to have the opportunity as everyone else. But we also recommend that these teams and these leagues really take a look at their practices, because the military made changes and saw a decrease in their death. So it's very manageable if you put in the precautions that every human should have.
That's a key point there. That's a key point. Water and rest.
Water. Yes,
water
that's essential.
So I'm not exactly sure what this question is, but she's asked, she says, priapisms?
Priapism.
Priapisms.
Yes.
I don't know what that is.
Another sickle complication. This is one of the things that distinguishes men from women. So this is one of our it's considered a medical emergency in our male patients.
Okay.
So it is a painful erection. So basically they're having the equivalent of sickle cell crisis in the penis. And it can lead to irreversible damage, erectile dysfunction, if not treated. So we usually start educating our young boys very early, prepubertal.
Right.
So they make an association that this is not a bad thing. This is not related to sex or anything like that. It's related to the sickle cell. If it's not going away, you need to be in the hospital, because long term you can sustain permanent damage. Okay.
Really good question, Christy. Thanks for bringing that up.
Yes.
And then, let's see, last question.
Okay.
So it's another one from Natasha. She came back and she says, when is hydroxyurea better than getting a blood transfusion?
I'm a little bit biased because I would say all the time.
That's okay.
To avoid blood products. So as a hematologist, we give blood very easily. But I think most of the population don't realize the serious risks. We have people sign consents all the time. But there's so many risks with blood transfusions that, it's not a benign thing.
Right.
Hydroxyurea safety has been documented. I think we cannot avoid blood transfusions, however. And so I think it always needs to be. So there's no reason someone can't be on hydroxyurea. If they have a bad complication, they may need blood with the hydroxyurea on board.
Okay. All right. So that is all the time we have.
Okay.
So we are out. We have had a wonderful chat. Thank you for all of the questions and for participating. Definitely want to thank both Children's Health again, as well as the Center for Cancer and Blood Disorders over at Children's. But mainly, we want to thank our lovely guest, Dr. Nero, for chatting with us.
This was fun.
All right, stay tuned. We're going to be live again on Friday talking about heart disease prevention. So tune in then.